This video focuses on the associations between physical activity and various health outcomes. Physical activity impacts a range of health outcomes, including all-cause mortality, cardiovascular health, metabolic conditions, body composition, systemic health, and mental and neurological well-being. We will use all-cause mortality as a primary example to illustrate the relationship between physical activity and health outcomes. Behavioral risk factors play a significant role in worldwide deaths. According to 2017 data, physical inactivity contributes to over 1 million deaths, highlighting its critical impact on global health. Global deaths attributed to low physical activity rose by 22% between 2007 and 2017. Specific conditions, such as type 2 diabetes, showed an even higher percentage increase in attributable deaths. Multiple supporting studies confirm the relationship between leisure time physical activity and all-cause mortality, showing a clear inverse association with mortality risk. Resistance exercise also demonstrates a positive association with all-cause mortality reduction, as shown in studies like the Women's Health Study and the Aerobic Center Longitudinal Study. Most of those studies are observational study. I won't go into detail of each study, but I want to shift you to another perspective. How can we know if the association from the study is real or not? If it is real, how strong the association is. This is a very important step, because this can give us more confidence to apply the results of the finding to the practical setting. To determine whether an observed association is real, we need to carefully consider chance, bias, and confounding. First, chance. We assess whether the findings could have occurred randomly using statistical significance. By convention, a p-value less than 0.05, or a 95% confidence interval that does not include one, suggests that chance is an unlikely explanation. However, statistical significance depends on both sample size and effect size. For example, a small study may fail to detect a true association due to low statistical power, while a large effect can be detected even with fewer participants. Second, bias. Bias can systematically distort the results. Selection bias occurs when the selection of participants is related to both exposure and outcome. For example, in a company, if death records are more available for sedentary office workers than for more active cargo workers, because cargo workers may have a larger personnel change, we may overestimate mortality among inactive individuals. Loss to follow-up is especially important in cohort studies. For example, if sicker and less active participants drop out, the observed association may underestimate the true harmful effect of inactivity. Reverse causation happens when illness leads to reduced physical activity, rather than low activity causing disease. Measurement error can also occur. Many studies rely on self-reported physical activity, which may be inaccurate and lead to misclassification. Now let's discuss confounding in detail. Confounding occurs when two or more potential risk factors co-occur within a group, making it difficult to determine the independent effect of any single risk factor. For example, if a physically active group is observed to have a lower disease rate than a sedentary group, but the active group also happens to be younger and to smoke less tobacco, we cannot conclude that physical activity protects against disease independently of age and smoking. The possibility of confounding is higher in observational studies, which are common in physical activity epidemiology, than in randomized controlled trials, RCTs. This is because random assignment of participants to groups in RCTs reduces the likelihood that comparison groups, e.g., exposed versus unexposed, differ with respect to potential confounding variables. A simple approach to address confounding is to stratify by the suspected confounder. For example, if higher age is positively associated with a higher disease rate and negatively associated with physical activity, dividing the number of cases in each exposure group by their cumulative age, e.g., using person years as the denominator, standardizes the rates according to age. This removes much of the confounding influence of age. Propensity score matching is a commonly used method for designing and analyzing observational studies to better estimate the causal effect of an intervention or exposure. The propensity score balances the frequency and weight of confounders between individuals who are exposed to the intervention, or primary risk factor, and those who are not. For example, outcomes can be compared between participants in an intervention group and those in a control group when they have the same propensity score. You can always find the confounder in a study by looking the footnote of the results table. For example, in this table, they mention the hazard ratio was adjusted for age, sex, education, country income level, etc. Those variables are regarded as confounders. When reviewing studies, you can also find the confounder by look for keywords like covariates, controlled, or adjusted in the statistical analysis section to confirm that confounding factors were considered. Then, let's shift to the question of how to determine the strength of a causal association. We typically assess this using 5 key aspects: temporal sequence, strength of association, consistency of results, biological plausibility, and dose response. We discussed dose response extensively in our previous class, so in this video we will focus mainly on the other four aspects. First, regarding temporal sequence, we need to examine the duration of the intervention or cohort follow-up to determine whether it is sufficient for the outcome, such as disease development, to occur. This is important because many chronic diseases, including cardiovascular disease and cancer, take years or even decades to develop. If the follow-up period is too short, we may not observe the true effect of the exposure on the outcome. For example, if a study follows participants for only 1 year, it may be difficult to detect meaningful changes in long-term disease outcomes, even if the exposure, such as physical activity, has a genuine impact. Next, for consistency of results, we examine whether similar findings are observed across different studies, populations, and settings. If multiple studies using diverse designs and conducted in different groups consistently show the same association, our confidence that the relationship is real increases. For example, many studies across various countries have found that higher levels of physical activity are associated with a lower risk of cardiovascular disease and mortality. The consistency of these findings supports a potential causal relationship. Conversely, if results are inconsistent or conflicting across studies, it may suggest that the association is influenced by bias, confounding, or differences in study design. Then, in terms of strength of association, we need to answer the question, is the magnitude of the effect large enough to matter in real life? In other words, the p-value alone cannot tell us whether your patients or clients would truly feel a difference. What matters is the magnitude, such as the odds ratio or relative risk. In a clinical setting, this concept is known as the minimal clinically important difference, MCID. The MCID refers to the smallest improvement that a patient considers worthwhile. There are several approaches to help determine the MCID. The most accurate method is to obtain direct qualitative feedback from your patients to learn whether they feel their condition has improved. Other approaches are statistical in nature. In this class, I will focus mainly on relative risk and odds ratio determination, as these are the two metrics we have discussed most often. A commonly used benchmark for the smallest effect size is approximately 0.25 for a protective effect, or 1.25 for a harmful effect. This means that if the risk is reduced by more than 25%, or if the benefit increases by more than 25%, we consider the effect to be clinically meaningful from a statistical perspective. Now let's look at some examples regarding strength of association, consistency of results, and dose-response relationship. In these examples, the outcome of interest is all-cause mortality. In the meta-analysis by Lolgen and colleagues, 2009, which included data from 1996 to 2008, the most active subjects had a 31% risk reduction in all-cause mortality compared with the least active. This finding indicates a moderate strength of association. This meta-analysis also demonstrated consistency of results, showing that the benefits of physical activity were observed across both men and women, as well as across different age groups, such as younger and older individuals. Another meta-analysis by Lolgen, 2009, found similarly consistent benefits. Both highly active and moderately active individuals, in both females and males, experienced reductions in all-cause mortality. Additional evidence supports the consistency of these findings across different demographic groups, including race, socioeconomic status, culture, and others. This demonstrates very strong consistency of the results. Now let's examine the strength of association across different domains and intensities of physical activity. In the top left panel, comparing the highest versus lowest levels of activity reveals substantial risk reductions. For example, total physical activity is associated with a relative risk of 0.65, corresponding to approximately a 35% lower risk of mortality. Similar patterns are observed for leisure time and daily living activities, whereas occupational activity shows a weaker effect. The top right panel illustrates that even small increases in activity matter. Each additional hour of activity per week reduces mortality risk, with vigorous activity demonstrating a slightly stronger effect than moderate activity. Overall, this slide demonstrates that physical activity has a moderate strength of association, approximately a 30% reduction in all-cause mortality, regardless of the type of physical activity. From the perspective of activity intensity, the benefits are relatively smaller. Nevertheless, engaging in moderate or higher levels of activity generally leads to greater health benefits. Looking at dose-response findings, we have discussed this extensively in the dose-response relationship video. To briefly recap, we reviewed a dose-response figure that helped inform the physical activity guidelines. The physical activity guidelines recommend that people engage in 150 minutes of moderate to vigorous physical activity per week, which equates to approximately 8.25 MET hours, to achieve a 75% reduction in all-cause mortality. As you can observe, the risk of mortality decreases as the volume of physical activity increases. Moving from physical inactivity to meeting the physical activity guidelines, and then to double the guidelines, the risk decreases by 11%. With further increases in activity volume, the additional risk reduction is only about 6%. Although there is no established upper boundary for physical activity, it is generally recommended not to exceed 5 times the minimum recommended amount to ensure safety. Now let's briefly discuss biological mechanisms. When examining mechanisms underlying all-cause mortality, it is helpful to break them down by specific disease outcomes, such as cardiovascular disease, cancer, or metabolic disorders. Understanding biological mechanisms is important because it provides biological plausibility, one of the key criteria for supporting a causal relationship. However, as physical activity epidemiologists, this is not typically our primary focus. Our role is mainly to observe and quantify associations. That said, we should still maintain a general understanding of key mechanisms. For more specific details, we often rely on existing literature, which is usually discussed in the discussion section of research articles. Let's use coronary heart disease as an example. Regular aerobic exercise leads to repeated exposure to hemodynamic stress, which promotes beneficial adaptations in both vascular function and structure. Functionally, increased blood flow during exercise creates shear stress on blood vessels, stimulating the release of nitric oxide. This improves endothelial function and promotes vasodilation. Exercise also reduces chronic inflammation, partly through the release of myokines from skeletal muscle. These functional improvements typically occur before structural changes. Structurally, regular exercise can lead to arterial enlargement, improved elasticity, and more stable atherosclerotic plaques, characterized by increased collagen and reduced necrotic core. Exercise also promotes coronary collateral circulation, improving blood supply to the heart muscle. In addition, physical activity improves cardiac autonomic balance, which helps reduce the risk of life-threatening arrhythmias. Exercise can also induce cardiac preconditioning, making the heart more resistant to ischemia-reperfusion injury. For cerebrovascular disease, the evidence I have found primarily focuses on aerobic physical activity. However, I believe there are other studies that have examined how resistance exercise may also benefit cerebrovascular health. Research shows that aerobic exercise improves cerebrovascular health through multiple mechanisms, including increasing cerebral blood flow, promoting angiogenesis via factors such as vascular endothelial growth factor, VEGF, enhancing neuroplasticity through neurotrophic factors like brain-derived neurotrophic factor, BDNF, reducing neuroinflammation and oxidative stress, supporting blood-brain barrier integrity. Collectively, these mechanisms contribute to neuroprotection and recovery, particularly after conditions such as stroke. Let's now turn to the pathological mechanisms of osteoporosis. Various internal and external factors, such as aging, sex steroid deficiency, mechanical unloading, and overuse of glucocorticoids, can cause bone resorption to exceed bone formation. And when that happens, it leads to osteoporosis. At the cellular level, the main pathological mechanisms include abnormal activation of osteoclasts. And this results from changes in 3 key processes: apoptosis, inflammatory reaction, and autophagy. In addition to these cellular changes, there are also epigenetic changes. These include alterations in non-coding RNA and DNA methylation, which can reduce the expression of osteogenic genes, the genes responsible for bone formation. So how does exercise help? Exercise induces changes in mechanical stress, hormones, and cytokines. And these changes can regulate the pathological progression of osteoporosis. Mechanistically speaking, exercise reduces harmful osteoporotic alterations by affecting 3 key processes: apoptosis, the inflammatory response, and autophagy. Furthermore, exercise may also influence epigenetic mechanisms of bone metabolism, specifically by regulating non-coding RNAs and DNA methylation. So in summary, exercise works at both the cellular and the epigenetic level to counteract the pathological changes of osteoporosis. Then, let's shift to the biological mechanism of physical activity in diabetes. In this figure, we see how glucose is normally regulated in the body. Insulin binds to its receptor on the cell membrane and activates an intracellular signaling cascade, including pathways such as PI3K and ACT. This signaling then leads to the movement of GLUT4 transporters to the cell surface. Once GLUT4 is inserted into the membrane, glucose can enter the cell and be either stored or used for energy. Overall, this process illustrates how insulin normally controls blood glucose levels through regulated cellular uptake. In contrast, this figure illustrates insulin resistance. Here, insulin is still present, but the signaling pathway is disrupted. This means insulin cannot effectively trigger GLUT4 translocation. As a result, GLUT4 remains inside the cell, and glucose transport into the cell is reduced. This leads to elevated glucose remaining in the bloodstream, which contributes to hyperglycemia and is a key feature of type 2 diabetes. This figure shows how physical activity improves glucose metabolism, even when insulin signaling is impaired. During muscle contraction, alternative pathways such as AMPK and calcium-dependent signaling are activated. These pathways also stimulate GLUT4 translocation to the cell membrane, allowing glucose to enter the cell without relying on insulin. This explains what we call the insulin-like effect of exercise. And it highlights why physical activity is particularly important for improving glucose control in individuals with insulin resistance or type 2 diabetes. Together, these three figures show an important story. While insulin resistance impairs normal glucose uptake, exercise can bypass this damaged pathway and restore glucose control through contraction-mediated mechanisms. Then, for the physical activity and cancer risks. Several hypothesized biologic mechanisms, whereby obesity, physical activity, and sedentary behavior influence cancer risk, are being elucidated through a combination of observational and experimental research studies. The biologic pathways relating these exposures to tumorigenesis are not yet fully defined or understood. But generally speaking, they center on maintaining a healthy body weight, thereby reducing the risk of metabolic abnormalities, chronic low-grade inflammation, and overstimulation of endogenous sex hormones. Evidence suggests that promoting physical activity and reducing sedentary behaviors can lead to cancer-preventing health benefits through these same mechanisms, independently of body fat. Furthermore, the accumulation of ectopic fat tissue, such as the storage of triglycerides in areas outside of adipose tissue, including the liver, skeletal muscle, the heart, and the pancreas, is of particular concern, since it can interfere with normal cellular and organ function, thus increasing the risk for many chronic diseases, including cancer. We just talked about insulin sensitivity in diabetes. Insulin not only plays an important role in glucose metabolism, but also in cell proliferation, cell death, and angiogenesis. Overstimulation of these biomarkers, their related binding proteins, such as insulin-like growth factor binding protein, and their signaling pathways, have been associated with increased risk of several malignancies, including breast, prostate, and colorectal cancers. However, the exact molecular mechanisms by which this risk reduction occurs are not completely understood. Adipose tissue is a metabolic organ primarily composed of adipocytes that secrete an array of bioactive signaling molecules, including pro-inflammatory adipokines and cytokines that may stimulate cancer development. By reducing weight through physical activity, adipose tissue decreases. Finally, sex hormone-binding globulin regulates the bioavailability of free estrogens, which, if unbound, are considered highly active and associated with increased risk of some hormone-sensitive cancers, particularly breast cancer. Androgens, produced primarily in men and to a lesser extent in women, have also been implicated in tumorigenesis. In the male prostate, androgen and androgen receptors regulate the rate of cell growth and death and are closely involved with the development of prostate cancer. In terms of physical activity and immune system, this figure illustrates how physical activity modulates immune function through both acute and chronic pathways. Acute bouts of exercise transiently increase circulating immune cells, such as leukocytes and CD8 plus T cells, thereby enhancing immune surveillance and the body's immediate capacity to detect and respond to pathogens. Moderate intensity exercise appears to optimize immune cell trafficking and function, whereas higher intensity activity can additionally activate anti-inflammatory signaling pathways that help regulate systemic stress responses. With regular long-term engagement in physical activity, chronic adaptations emerge, including immune system remodeling, preservation of thymic output, and a sustained shift toward an anti-inflammatory immune profile. These adaptations collectively strengthen immune regulation and resilience. Together, the acute mobilization of immune cells and the chronic anti-inflammatory adaptations converge to enhance overall immune competence, improve vaccine efficacy, and reduce the risk of severe infectious disease outcomes. This conceptual diagram summarizes 4 key pathways through which behavioral patterns may influence psychological well-being. However, for the purpose of this discussion, I want to focus mainly on the biological mechanisms. Prior research suggests that physical activity may influence mental health through the modulation of neurotransmitters, such as serotonin and dopamine. These chemicals play important roles in emotional regulation, memory, and cognitive flexibility. Regular aerobic exercise has also been associated with elevated levels of brain-derived neurotrophic factor, which supports neuroplasticity and cognitive function. Beyond these neurochemical effects, exercise may also exert antidepressant benefits by modulating systemic inflammation. For example, Lovbrat and colleagues demonstrated that patients with depressive symptoms who engaged in exercise interventions exhibited significantly reduced serum interleukin-6 levels, along with improved depression scores, compared to control groups. So in summary, the biological pathways through which physical activity affects mental health include neurotransmitter regulation, neuroplasticity via brain-derived neurotrophic factor, and reduction of systemic inflammation. Beyond those biological mechanisms, there are still several important questions that remain unanswered regarding the relationship between physical activity and all-cause mortality. First, from an intensity perspective, there is a lack of evidence to answer the following question. Does vigorous activity offer benefits beyond its contribution to total energy expenditure? Much of the existing evidence supports the benefits of light and moderate physical activity. However, there is a relative lack of evidence on the specific benefits of high-intensity activities. Second, there are questions related to the frequency and timing of physical activity. For example, are multiple short bouts of physical activity versus a single continuous bout differentially associated with mortality risk? Is exercise performed in the morning, afternoon, or evening differentially associated with all-cause mortality? In summary, although some evidence exists for these questions, it is not yet sufficient to support decisive conclusions. Now let's wrap up a little bit before we dive into some of the risks that physical activity may bring. We've covered quite a lot of ground. Let me briefly summarize what we've discussed so far. First, we talked about how to determine the accuracy of the evidence and the strength of evidence from different perspectives, including aspects such as temporal sequence, consistency of results, biological plausibility, and dose response. We also briefly reviewed some of the key biological mechanisms underlying the relationship between physical activity and several major health outcomes. So with that foundation in place, let's now turn our attention to the other side of the coin, the potential risks associated with physical activity. This figure shows injury patterns across different gender groups. So what can we observe? For males, injuries are primarily associated with football. For females, injuries are most commonly associated with gymnastics and cheerleading. These findings make sense given what we know about gender differences in sports participation. The gender difference in engagement, that is, which sports individuals are more likely to participate in, also plays an important role in explaining these injury patterns. Now let's take a look at body part injury distribution. For both women and men, the results are consistent. The knee is the most likely body part to be injured, followed by the foot and then the back. However, there is a striking difference when we look at the Achilles tendon. Among men, 5.7% of injuries involve the Achilles tendon, whereas among women, only 0.4% of injuries occur at this site. That is a really interesting finding to me. Beyond body injuries, there are also some medical injuries or illnesses associated with vigorous physical activity. Cardiovascular complications of vigorous physical activity include cerebrovascular accidents, or strokes, symptomatic cardiac arrhythmias, aortic dissection, myocardial infarction, heart attack, and sudden cardiac death. The main causes of these complications differ by age. In young subjects, congenital abnormalities are the primary cause. In adults, atherosclerotic coronary disease is the main cause. In addition to cardiovascular risks, there are also other risks related to the musculoskeletal system and pulmonary system. Other potential risks included gastrointestinal system, allergic reactions, gynecologic system, endocrinologic system, renal system, hematologic system, and thermal regulation. I won't go into detail on these because I am not an expert in exercise injury or therapy, so I don't think I can provide very detailed comments on that information. We must also consider psychological hazards, such as exercise dependence, which can lead to negative emotional and social consequences, as well as body image disorders. There is some concern among mental health professionals that the disciplined training and social climate in some sports and leisure time fitness activities, particularly those that emphasize lean body composition and dietary restriction, can increase the risk of eating problems or add to existing eating problems among participants. Harvard-affiliated researchers Dr. Phillips and Dr. O'Sullivan proposed a form of body dysmorphic disorder that they have termed muscle dysmorphia. This is a condition in which a person develops a pathological preoccupation with his or her muscularity. They presented case studies concluding that muscle dysmorphia was associated with severe subjective distress, impaired social and occupational functioning, and abuse of anabolic steroids and other substances. The investigators next tested the hypothesis that men in Western societies would desire to have a leaner and more muscular body than they actually had, or than they perceived they had. They speculated that this wide discrepancy between men's ideal body image and actual muscularity might help explain muscle dysmorphia and some anabolic steroid abuse. There have also been case reports of excessive involvement with, or dependence on, leisure exercise training. However, very little is understood about the origins, valid diagnosis, or mental health impact of exercise abuse. Though exercise abuse or addiction is a problem requiring medical treatment for some people, its prevalence is probably not high enough to warrant population-level interventions. The real problem in the United States is too little, not too much physical activity. However, from epidemiology perspective, no controlled prospective studies have yet been conducted to show that these conditions directly result from participation in leisure time exercise by healthy people. Nonetheless, their appearance in clinical and scientific literature illustrates that their measurement, prevalence, and health consequences require epidemiologic study. Now let's shift to our last topic in this video, prevention strategies. There are several effective strategies that help prevent injuries. Previous studies have provided strong evidence supporting these strategies. One interesting finding I want to highlight is the role of insoles. Our department has a research group dedicated to comparing how different types of insoles can reduce the risk of injuries during sports, or how they can help maintain better motor balance. This work is very innovative. As for other strategies, such as wearing protective gear and multi-component interventions, these are likely familiar to all of you. Another interesting finding for me is related to stretching. The studies show that stretching does not protect against injuries or muscle soreness. This is not consistent with what I used to believe, so I remain somewhat skeptical about these findings. How about you? Could you find more evidence to debate these conclusions? Regarding warm-ups, there are also several important questions raised based on the finding. Do warm-ups or stretching help with preventing injury? Does timing matter? Do different ways of stretching matter? The last part is the impact from the environment, such as exercise surface, temperature, and air pollution, on injury risk. Air pollution, in particular, increases cardiovascular and pulmonary mortality.